Great, excellent. Good morning, everybody. Welcome to Coplow Comparative Ocular Pathology rounds this morning. I'm Dr. Jamie Miller, one of the staff pathologists, and I'm going to get us started with our first two cases. All right. This first case is from a 7-month-old female spayed domestic long-hair kitty cat. This is the right eye that we received, and the history that came along with it was that the globe had moderate to severe conjunctival hyperemia with moderate chemosis, 3+ flare, a narrow anterior chamber, fibrin clot in the anterior chamber that seemed very focal. The cat eye had rubeosis iridis, mydriatic pupil, and the lens in the iris seemed to be being displaced forwards in the globe. They said that there was evidence of complete retinal detachment with the retina being pushed up against the back of the eye. They said yes to glaucoma, and the other eye is normal and no other medical conditions of note were made. We did get a lovely little plea from the submitted clinician that they wanted some help with this globe because they could not determine why such a horrible panuveitis blew up in this little kitty cat. They said that they did consider feline infectious peritonitis, but the cat has no other symptoms and the blood work was not supportive. The albumins and globulins were normal, and the kitten was otherwise acting normal. So always nice to have little extra notes there when we're grossing our specimen. So this is the hemisection of our formalin fixed globe. We have cornea at the top. You can see our iris leaflets here, and indeed the anterior chamber is pretty narrowed. It's a little bit hard to tell on this cut view, but there is a little bit of some cloudy material in the anterior chamber that would go along with the fibrin clot that they were seeing. Here's our lens. Here indeed is that detached retina, and it's very thick and very white. And we can tell that the subretinal space and even the vitreous has this like cloudy fluid. And you can see some kind of whiteness going on, little splotches here in the choroid. Oftentimes with feline infectious peritonitis, the more classic appearance of the material in the globe is more like of a cloudy gel. It's a bit more solid because it's a quite hyperprotinaceous exudate that's in the eye. And that wasn't quite the case with this one, but we will look at it histologically and see what we got going on. So I'm going to start with the subgross view of our eye. So again, cornea is up at the top. Here we go. Iris leaflets here. Again, anterior chamber is pretty narrowed. Do have a little bit of stuff, pink material in the anterior chamber. Here's our lens. It's not too bad looking. And again, here's our detached retina. It's very purple, as is the rest of our choroid as we go around the back of the globe. So just indication that there's increased cellularity going on in those tissues. And so we'll take a look. This happens to be a little bit deeper level of this globe. So we don't quite have the optic nerve head. We got a little bit of the optic nerve coming out from the back of the globe. And then this is an additional radial section from the globe that we often trim in with our eyes. All right. So here we have our globe. All right. All right. Cornea on the left. We can see our iris leaflets here. Again, very narrow anterior chamber. Here's our lens coming into view. Here is our ciliary body, what's left of it, along as the choroid. You can see, again, very purple, very infiltrated by cellular infiltrate. Our detached retina. You see it come up. And again, as the clinician stated, did seem to be a little bit plastered on the back of the lens. We can see here towards the periphery, we lose kind of that cellular detail. It gets very eosinophilic and light, indicative of necrosis. And then we do have a little bit of eosinophilic material kind of floating around in the subretinal space, but again, it's not hyper-eosinophilic and kind of solid looking like a gel. So if we drop down and look at the cellular infiltrate, we're in the dorsal portion of the choroid here. We've got these tapetocytes, so this is the tapetum. And we can see that as we get closer that our cellular infiltrate here is a bit of a mixed population. So we've got some neutrophils here with these segmented nuclei. We've got larger polygonal cells with round nuclei that are indicative of macrophages. And then kind of deeper in the choroid, we have some smaller lymphocytes and plasma cells here. And so that's a pretty representative look of what all this inflammation is in the choroid and the ciliary body. It's a little bit less in the iris, but it is still there. So we have a pyogranulomatous to lymphoplasmacytic, panuveitis, and endophthalmitis. It's, again, similar material or similar cellular infiltrate here in the subretinal space and coming in and effacing our retina. So we can add retinitis to our list of morphologic diagnoses. And then here, again, that loss of detail here in the retina, so some necrosis. We do get a little bit of posterior migration of our lens epithelium, so there's a very early subtle cataract in this eye. But again, main thing is this pyogranulomatous, lymphoplasmacytic, panuveitis, endophthalmitis, retinitis. It didn't extend past the optic nerve in the sections I examined. So this sort of cellular infiltrate in a young kitten, we do start to think about infectious etiologies, including fungal, and definitely FIP is still on the list. We did do a GMS silver stain for fungus and did not find anything that looked fungal or especially for like histoplasma and such like that. So we did offer that even though it maybe isn't classic clinically and what we were seeing grossly in his with the lack of that high protein fluid in the eye, that we could still do FIP testing with immunohistochemistry. So they did do that. So this is the immunohistochemistry for FIP that we send out to Cornell. And it is a red chromogen stain. So this red staining here is positive for the viral particles in the macrophages in the cellular infiltrate. So despite not having clinical signs in this young cat, and again, lacking that sort of classic high protein fluid in the eye, the cat does seem to have feline infectious peritonitis virus going on. So again, young kitty cat with pyogranulomatous lymphoplasmacytic inflammation in the globe, either with or without that high protein exudate. Think something infectious, especially FIP or fungal, and test appropriately. So just a nice little case. I had the immuno back. Thought I would show it. All right. All right, next up, I've got another cat for you. This one is also a younger cat. This is a 2-year-old female spayed domestic medium hair cat. This is the left eye that they said that the globe was ophthalmic and had some periocular soft tissue swelling. They noted multifocal irregular soft tissue pigmented masses in the anterior chamber iris that were contacting the cornea, filling the anterior chamber, and beyond that, they couldn't see much into the eye. They said yes to glaucoma. The other eye was normal. They also note that the cat is feline leukemia virus positive as well. So this was the hemisection of our globe, again, with the cornea at the top. We did think that the globe was enlarged. We did note that kind of the peripheral cornea was kind of pigmented circumferentially. caused by whatever was going on in this anterior chamber here. There's a lot of dark red material here. There was also some limbal bulging, mostly dorsally around the globe. But we can still see our iris leaflets are here. They do kind of blend with the hemorrhage a little bit. And then we still have some more hemorrhage in the posterior chamber, a little bit cloudy lens, but the back of the globe was looking relatively unremarkable. So, take a look there. Our subgross. Go get that a little bit focused for you. All right. So here is our cornea at the top. We can see that at the peripheral cornea and in the limbal area, there is indeed some red staining, so some hemorrhage and stuff that probably accounted for some of the changes we were seeing grossly. Here's all that hemorrhage in the anterior chamber. Again, kind of blends with the iris here. A little bit more lighter eosinophilic stuff, so some more necrosis and probably some fibrin going on as well. And then we hit the back of the globe, a little bit of cupping in the optic nerve. Take a little bit closer look at that. Right. Leave that up there. All right. So, all right. So again, here we've got our cornea at the left. We can see that there's some cellular infiltrate and some hemorrhage in the peripheral cornea and the limbus. Here's our hemorrhage in the anterior chamber, again, blending with the iris, which seems to be necrotic as well as a little hypercellular. And then we look at the infiltrate over here, and we start to see some hemorrhage, but then we also start to see some things being formed here by the cellular infiltrate. So we have a relatively monomorphic population of spindle cells, and they are forming these blood-filled vascular channels. So they have scant eosinophilic cytoplasm. They have pretty oval and round, very plump nuclei with finely stippled chromatin and pretty prominent nucleoli. There's occasional mitotic figures here and there. Here's one for you. You can see in some regions it gets a little bit more solid, but you can still see the vascular channels being formed. So this is consistent with a malignant vascular tumor, so hemangiosarcoma. And if we follow inside the eye here, so here's our iris, and again, a lot of that more brightly eosinophilic material, pale, some fibrin, some necrosis, and you can still see the neoplastic cells here. Again, still forming blood-filled vascular channels. And so it's kind of lining the front of the iris as well as infiltrating the iris. You can see here where kind of on the posterior portion of the iris, they get, again, a bit more solid. They start to look a little bit more polygonal. You get some increased in anisocytosis and anisokaryosis, so variation in cell shape and size. You can see all the hemorrhage. And if we flip back to our extra piece here. So again, you can see how extensive just the tumor is in the limbal area. Again, front of the iris, it also starts to track through the episclera. And if we come back here to the ciliary body, we can also find our neoplastic cells within vascular spaces here. A little bit more solid portions of the neoplastic cells. So there's also like vascular invasion of this vascular tumor. And then just to finish up, there was evidence of glaucoma in the retina and optic nerve. So in cats, usually that is a loss of retinal ganglion cells and some cupping of the optic nerve. And again, it's also very gliotic in here as well. So this was like just a really unusual tumor, especially in a young cat, have hemangiosarcoma. In the eye, and also with the vascular invasion. It's hard to tell if this is a primary tumor in the eye, because oftentimes hemangiosarcoma is metastatic in the globe. And you've got the vascular invasion, so it's either maybe potentially coming or going from somewhere. So definitely staging the patient was recommended for this case.
Because they're in the ciliary body
Mhm.
vasculature,
Mhm.
that means it's coming from elsewhere in the
From
body,
elsewhere,
unless
okay.
I'm incorrect, right?
Ciliary body. I think it could be, but it could also be infiltrating the stroma from outside and then getting in there.
Okay. Yeah, okay.
Yeah, no, I see what you're
Good
saying,
point,
because
yeah.
it's,
I
you
see.
know,
Yeah.
it's the,
It seems
it's
so
less likely.
proximal
Yeah,
there,
it's, yeah, you're right
you
about
know,
that.
so anyway, who knows?
Yeah, who knows? It's always a problem with hemangiosarcomas that we get. The way we define metastatic neoplasm or tumors in the eye is by their distribution, right? Which it's usually how we see hemangiosarcomas in the eye to begin with. They tend to be on the surfaces of the eye, kind of, spreading around, less than forming a well-delineated mass. So I don't know if we can use the same standards to define metastasis for hemangiosarcomas that we use to other tumors in the eye, because it almost always presents like that. And as we know, hemangiosarcomas in dogs like to metastasize to and from whenever they start. So it is even harder to find, if we find a larger primary mass somewhere in a classic locations like the spleen, the spleen base of the heart, or even the skin, you might assume that was metastasis to the eye, but then you can have miliary, spread somewhere like in the lungs or in the liver, and then we'll probably not know where the primary mass is. So we always suggest that the ophthalmologists, the clinicians, go back and take a harder look and do a systemic workup to rule out the presence of a primary hemangiosarcoma elsewhere and a potential metastatic disease from the eye to somewhere else too.
It's just a second, this would be an unusual, not because it's just young, but the eye isn't necessarily considered a primary spot unless I'm missing something.
There are blood vessels everywhere.
Right.
Yeah.
Yeah, it's one of those things where like it could be,
It could
but like,
be,
yeah,
it's probably very
not,
rare.
yeah,
But you
exactly.
can have primary ones.
The question is, why would that be atypical? First, a cat, which is not
Cat,
usually what we see.
young.
A young cat, it's another weird presentation. And second, metastatic versus primary. Primary, we see them in dogs, but we're kind of biased in terms of like thinking that how common they are, because we see a lot of cases and I think they're relatively rare.
I think the ones that are more convincing are the really benign looking ones.
Right.
That just look like a hemangioma
Exactly.
in like the iris or something.
Yeah, and those I think we tend to be more comfortable in thinking they could be primary versus something like that. And we're not even getting into the whole problem with sometimes even defining that that's a tumor is a problem, because when you have chronic inflammation and chronic hemorrhage inside the eye, you end up with lots of reactive proliferative vessels, right? And you might end up with something that looks like that, like a chronic organizing hemorrhage with proliferating reactive vascular endothelial cells. And it's not uncommon for us to stare at those things and like, is this neoplasm or is just reactive, right? And we might end up at the same spot where we say, well, we don't know about these, we might be prudent to go and take a look elsewhere. And
Stage that patient.
Stage the patient.
Stage it.
Yeah. So Dr. Naranjo wrote here, so for tumors other than hemangiosarcomas, finding intravascular invasion in the ciliary body is an indication of metastasis to the eye, arriving rather than leaving
That's what I'm saying. So
Yeah.
the vasculature of the eye, just to review real quick, all of it that feeds the entire uveal tract, which is essentially the vascular tissue in the eye, comes from at the optic nerve. So the blood vessels come into the uvea there and then branch all the way around in the uvea up into the iris and ciliary body. So anything that's in a blood vessel in the ciliary body presumably has come from the body coming up into the eye. Unless, as Leandro pointed out, they could have gotten into the ciliary body stroma, gotten in there, and then, but anyway, so.
Yeah, the answer, Dr. Naranjo, is we don't know, but that's a useful way to think about it.
At least prognostically speaking too, coming or going, it's not a great outcome.
Right. Yeah. If things are coming or going, it mean they're moving. And tumor neoplastic cells moving around, regardless of directionality, is bad. And Dr. Dubilzig is on top of our database that I checked, and 10% of our feline ocular hemangiomas are less than 4 years of age.
Outstanding.
See, we just said that was atypical but still atypical, but not unheard of.
And he said hemangiomas.
Yeah. All right.
This one didn't look benign.
No.
Exactly.
Is there an association with like the FELV and that and these stuff?
The question was any association with FELV. That is such a hard thing to answer,
Yeah.
right? Because if you get a little history, a lot of them have tested positive for FELV, FIV, and herpes at some point. And
Yeah.
I think teasing out any statistically significant correlation can be problematic.
Sure.
So, good question. It's possible, but I think we don't know. That's
Solid, maybe.
yeah, still a maybe.
Alrighty. Next up, this is a 4-year-old Labrador Retriever mixed dog. They say blind abnormal cornea in the right eye, which is this one. And they suspect prior trauma. They're unable to examine much of the eye due to anterior synechia, which is where the iris is stuck to the cornea. Let's see here. And they say, as far as the cornea goes, bubbled epithelium protruding from corneal surface. And they couldn't really see anything else inside this eye. They say it's been present since the dog was at least 8 months old, so quite a long time for this. So here's the clinical photo that they provided, which is really cool. So you can see how irregular and sort of bulbous the corneal surface is. And it's also quite brown right under there. And when you can see that there's brown just under the cornea, that's usually the iris that's stuck to the back of the cornea. And you can just appreciate how irregular that corneal surface is. When we got the globe, I think it was slightly collapsed. And here's the front view, which you can kind of appreciate if this was a fully inflated globe, would have looked just like this on the surface. So we've got some more opaque areas of the cornea and then some darker areas. And then on hemisection, as I said, the globe was collapsed. Here's cornea here, and here's sclera. You can see the limbus is kind of clear right there, where we go from opaque white to slightly less opaque. That's corneal stroma, and you can follow the sclera around, and then somewhere over here, it's discontinuous. You can see this little sort of blurb of uveal tissue coming out, a defect here. And then the front of the eye, there's really no appreciable corneal stroma at all. So this is kind of a cool case. Okay, so right back here is the back of the eye. We didn't quite catch the optic nerve head, but you can see the detached retina is sort of pointing toward where it would have been attached. And then we're going to spend most of our time up here in the front. So here's the limbus here. So we've got scleral collagen leading into peripheral corneal stroma. Here's that little one of the little blurps of uveal tissue coming right out of defect, and then you can see it's happening on the other side as well. So here we've got this little sort of bulbous sort of balloon of corneal, well, surface epithelium with some uveal tissue coming into it at the periphery. And then we have epithelium that continues across the surface on top of some sort of disorganized fibrous tissue. And then we have what is more easily recognizable as iris tissue coming up through that really broad defect in the cornea. So I was going to start over here because I thought the corneal stroma was a little bit more apparent there. So the limbus typically has a row of melanocytes in it in animals that have normal pigmentation, not albinos, I mean. So you can see a few melanocytes here. Here's our scleral collagen, which is it's a little bit sort of regularly irregular the way it's arranged. And then when we move into the peripheral corneal stroma, it's slightly better arranged, but in this case, this is abnormal corneal stroma. So we'd probably just consider this fibrotic corneal stroma. And then we come right here, and then that corneal stroma just completely disappears. And what we have is this outpouching of uveal tissue and with surface epithelium on it. The surface epithelium is heavily pigmented. You can see all that melanin pigment in there. There's probably a few melanocytes in there. And then here is uveal tissue that's prolapsing up into the defect. And the surface epithelium really is migrating right across the surface of the uveal tissue here. And here we have more densely fibrous tissue, which I think is just fibrosis that has been laid down on top of prolapsed uveal tissue. So we have what is just a very broad corneal absence. Within this fibrous tissue, we have some basophilic granular material here that subtends the epithelium, and it sort of accumulates in sort of chunky accumulations here. And then it also subtends the epithelium in a much more finely granular, sort of spread out way. This is mineral, and this is what we call band keratopathy. And in animals, probably in people too, but in animals, we see sort of two forms of it. One is where we have this really fine dusting of it right up under the epithelium. And then in other cases or in other areas in this eye, we have this more sort of chunky, amorphous accumulation of it. We tend to see the finer subepithelial, immediately subepithelial version of it in older animals or adult animals. And then we tend to see this sort of really thick, chunky stuff like this in younger animals, and I don't know why that is. And it's often younger animals that have abnormal eyes. Of course, those are the only eyes that we get in Coplow, are the abnormal eyes, so I don't know if it occurs in more clinically normal eyes. So as we move back down here, you can just see that uveal tissue is prolapsing out, and this is probably all, it's empty space here on this slide, and it's probably filled with aqueous humor that's being produced by the ciliary body and trying to exit the eye in any way that it can. So it's sort of ending up in this sort of subepithelial bulla, cleft, I'm not sure. And so here's any of the remaining corneal stroma on this side of the eye. We do have this interesting little sort of fusion of corneal epithelium here and conjunctival epithelium here. This would be the bulbar conj coming in. This is what we call symblepharon. And let me see if it's on the other side. I can't remember. Not really. So the anterior chamber is completely collapsed. We have nothing remaining of the anterior chamber. I can't remember if I found any Descemet's membrane anywhere. I don't think I did. So we have a broad absence of Descemet's membrane. As we move back into the eye, oops, can't go that low. It's pretty empty in here. There's no evidence of lens. Sometimes we'll see lens capsule fragments in eyes like these. We do have a little bit more of that fibrosis that's lining the back of the iris and the ciliary body surface. And then we also have the diffusely detached retina that's variably atrophied. As I said, we didn't sample the optic nerve, but it would be back here somewhere. This is close to the optic nerve here. So this is a really interesting set of lesions, which basically we have broad corneal absence and we have aphakia, which means lack of lens. In this case, the aphakia could be due to extrusion through a broad corneal defect, which is probably likely in this case, but we can't rule out something like congenital aphakia, which is true lack of development of the lens. There's quite a bit of very detailed interplay between the lens and the ocular surface during development. And when the lens fails to develop, it induces really severe abnormalities of the anterior segment. And any anterior segment refers to anything in front of the lens, so the anterior uvea and the cornea in particular. So I don't know what happened to this eye. They suspected trauma. I think trauma could explain this, but it's a little bit unusual to have complete absence of the cornea. This eye actually shares a lot of features in common with a syndrome that we discuss in cats, called feline early life ocular disease or feline early life eye disease, which equals broad corneal absence, broad iris prolapse through a corneal defect. And we typically ascribe that in cats to early life or probably in utero feline herpes virus infection, which leads to corneal necrosis and then all that comes after that. We don't recognize severe herpes virus associated eye disease in dogs, though it is reported. I think it's more of a clinical disease. But I was really struck by the similarities between this dog eye and a 4-year-old dog and what we see in kittens. I also think in cats, in a lot of cat cases, there's a very gray area between the lesions that we would ascribe to feline early life ocular disease, which we assume is associated with herpes virus, and congenital or developmental defect of the eye involving the cornea and the anterior segment, which is in human medicine under the umbrella of anterior segment dysgenesis. In our practice, we often refer to anterior chamber cleavage syndrome and Peter's anomaly, which are sort of synonyms for the same thing, and are those terms are perhaps antiquated, but we tend to continue using them. And they probably refer to very specific syndromes in human medicine that we don't really have the ability to differentiate in the eyes that we see. So that was a whole lot to say about this eye. Let's go to my diagnoses real quick. And then, so interestingly, they say that the other eye of this dog is small with a cloudy cornea. So this dog has bilaterally abnormal eyes. In my mind, that makes a congenital problem a little bit more likely. And so I think my bias is sort of toward that, sort of more of a congenital, like Peter's anomaly, kind of anterior chamber cleavage syndrome problem. But anyway, so we have extensive corneal absence with broad iris prolapse and reepithelialization, and there's a lot more going on there. Let's see here. As I said, aphakia, presumed extruded, but it could have been congenital aphakia, which would have contributed to abnormal development of the anterior segment. Oh, and then also in general, really severe ocular surface chemical injuries can probably lead to a broad corneal absence like this. That would be an acid or a base injury mostly, and I can't remember which one is more likely. So it's possible that this dog was exposed to something like that, but you would think that if it was that bad, the eyelids would be and the periocular skin would be affected, and they didn't mention anything, and the clinical photo doesn't really look like there's anything wrong with the rest of the periocular tissue on this right side. So anyway, I just thought this was a cool case. I'm kind of hung up on congenital abnormalities in young animals, and so I just thought it was cool.
Also, the fact that I had time to reorganize and reepithelialize the surface.
Yeah.
Something that we think it's associated with the fact that that happens before the eyelids are open and the animals are young. And it's
Yeah.
kind of an older dog and the chemical burn kind of thing would,
Yeah,
you
good
know what I
point.
mean, it will be,
Yeah.
I don't know, I agree with you.
Yeah,
Cool case though.
yeah, cool case.
Can you read the timeline again? Like run to the signs?
Let's see here.
Question was about the
Well,
timeline.
yeah, the timeline was the question. So they say that the duration of problem for this eye was at least since 8 months old. And this is a 4-year-old dog. So perhaps, I mean, we don't know. Maybe the dog was adopted at 8 months old and it was present. Yeah. Um, so there we go. Cool. All right, next case. This is an eye from a 3-year-old husky. I'll just spill the beans now to make this presentation a little bit shorter. They say history of bilateral uveitis and Uveodermatologic syndrome, or VKH-like syndrome, had already been diagnosed on both skin biopsy and removal of the other eye before this. This was a dog. Well, okay, I won't say that. Anyway, so they say bilateral uveitis and secondary glaucoma, both eyes. And so this was the second eye to be enucleated. Let's just leave it at that. So as you can see, here's our eye. So cornea is always at the top. This sort of off-whitish, yeah, bluish color of the iris is consistent with what we call a blue eye in dogs. So this is a blue-eyed husky. We have the lens here looking relatively normal. There's very little pigment in the rest of the eye. Sorry, in blue eyes, there's always pigment on the ciliary body epithelium and the back of the iris. And the back of the iris pigment is actually what gives the iris a blue color when you look at the eye in an intact dog eye or human eye for that matter. What we do see here, there's some sort of spotty pigmentation in the back here. So what we're seeing is choroidal pigment or RPE more likely. So the retinal pigmented epithelium, which has pigment in the non-tapetal area of a dog eye. So I think this is probably the dorsal aspect of this eye, and this is the ventral aspect of the eye. So we're seeing some retinal pigmented epithelium, which is not diffusely consistent across the surface there. This may have been the second half of this eye. I can't remember. Anyway, because I can't tell. Maybe this is the optic nerve here. Anyway, so let's just go ahead and dive right in. So VKH is an autoimmune problem where the immune system attacks melanocytes and destroys them, and it leads to depigmentation. In dogs, it can affect the skin, which is often associated with the face, so around the nose, around the eyes, and it can affect the eyes. In humans, it also tends to affect the CNS because we have melanocytes that inhabit the meninges at least. Which is interesting because I'm sure dogs do too. So there's a weird disconnect there, which is why we refer to it as VKH-like syndrome, because our dog patients don't have the CNS abnormalities when they have this disease. I will say that we see VKH relatively commonly in Coplow, even though clinically and across the veterinary world, it's assumed to be most common in the Arctic breeds. So your Akitas, your Huskies, I can't think of who else at the moment. However, we see it in a very broad range of breeds. Oh yeah, maybe Samoyeds, yeah. But anyway, we see it in a very broad range of breeds. And I have various theories on why that is. But also, most of the cases we get do not come with a history of dermal lesions. So they can develop the uveal and the ocular problems associated with this disease in the absence of skin disease. I don't think really anyone understands why that is. But so anyway, in a blue eye, there's a lot less melanin pigment around to be affected by an immune response. So generally speaking, blue eyes of dogs with VKH have a lot less intense inflammation than we see in a brown eye. So here is this eye. Here's the cornea. I didn't do the subgross, but so generally speaking, this is an iris that is almost completely devoid of pigment. There's a little bit of pigment here in the stroma. And one thing that we can appreciate is that the iridociliary, well, the iris epithelium, which is on the back of the iris, is very hard to find at this low magnification. As we move back onto the ciliary body, here's our ciliary body plica, you can pick up a little bit of that pigmented epithelium. And then, but it's sort of intermittently absent or hard to discern. It's a little bit more obvious on this side where we have a little bit more of a continuous pigmented layer of epithelium there. As we move back, so blue eyes tend to have almost no choroidal pigment at all. And so what we are seeing here, we do see a little bit of choroidal pigment in this eye. And some of that might be RPE pigment, so we'll have to take a closer look. I think this is probably the dorsal side, which would be devoid of most pigment because the RPE is not pigmented over the tapetum. Okay, so let's take a quick look. The inflammation we typically see in VKH eyes is lymphoplasmacytic and granulomatous. And the granulomatous component is often composed of large numbers of macrophages that have melanin in their cytoplasm because they have come in to clean up after lymphocytes that have attacked the melanocytes have broken those melanocytes open and released pigment. So what we're seeing here is not very much inflammation at all, which is really common in blue eyes with VKH. These guys are actually plasma cells. And then here, most of these cells that have melanin in them, they're kind of round, and the melanin granules tend to be a little bit more coarsely granular than we see in native melanocytes. So these are all melanin-laden macrophages here that have come in to clean up. And where did that melanin come from? It could have been some melanocytes in this stroma. It could have also been melanin from the iridociliary epithelial cells. So the iridociliary epithelium, the iris epithelium, is sort of intermittently replaced by a spindle cell membrane that then causes broad posterior synechia. You can see that how that iris leaflet is really fused to the front of the lens capsule here. So let's go back and look real quick at what we were seeing over here. Pigment in the choroid. So it's kind of a similar story where we see relatively little pigment in the choroidal stroma. In this case, we are seeing some inflammatory cells here as well. And then we're also seeing the RPE cells, which are intermittently absent. So here they're present, and then here they're absent in this area where the retina is, well, it's atrophied here, but the retina is lacking its inner and outer segments of the photoreceptors, and here's where the RPE is present again. So more than likely the RPE has been affected by the the inflammatory response. So here's a nice row of RPE cells, and then they're absent. So we assume that the RPE has been affected by the immune system.
Some of the pigment in the choroid there, I think it's also RPE pigment, right?
Oh, yeah, probably, yeah. So they said this eye had secondary glaucoma. Let's just look real quick at the ganglion cells. We tend to focus on the retina right around the optic nerve to assess the number of ganglion cells, and we're really not seeing very many on this side of the retina. I think I saw a few over here. Yeah, here's a few remaining ganglion cells, but overall very few. And then the optic nerve itself, well, the optic nerve head doesn't look too bad, but the optic nerve is looking a little bit busier back here, so maybe a little bit gliotic. But anyway, so they reported elevated IOP, so secondary, or well, glaucoma in this case. I'm super biased, and almost all blue eyes that we see in Coplow have goniodystegenesis. I tried really hard to convince myself that this was goniodysgenic, and I couldn't. So this might actually be a blue-eyed husky that does not have goniodysgenesis. I know, which is amazing. The posterior synechia up here, where the iris is fused to the lens, probably prevented aqueous humor outflow through its normal path. So that does provide a very nice explanation for the glaucoma in this eye. Okay, I think I covered the most important stuff. So as I said, VKH had already been diagnosed, which made this a pretty easy case for us to look at and make the diagnosis of. So basically, a very mild lymphoplasmacytic and histiocytic panuveitis with melanin-laden macrophages and some iridociliary changes, loss of RPE, and this is consistent with uveodermatologic syndrome in a blue eye, which overall, as I said, because there's so much less melanin, the inflammation tends to be a lot less intense. So that is all I have to say. And now somebody else gets to present. Any questions?
Okay. So I have two more cases. I can get through at least one, maybe both. We'll see. So our first one is going to be both globes from a 7-year-old male castrated domestic short hair cat. This one will actually dovetail nicely with Jamie's first case. And the history that we got is that both eyes were blind. In the right eye, they described aqueous flare, bolus retinal detachment with perovascular infiltrate, as well as an infiltrate in the subretinal space. In the left eye, there was a advanced cataract, so they weren't able to evaluate the posterior segment and say much else about that. So here are the gross images of both hemisected globes, right and left. In our right eye, we can certainly verify that there is a retinal detachment. Here's our retina here. It looks kind of opaque and maybe a little thickened. And then there is also some sort of infiltrate or this kind of tan material in the subretinal space, maybe also thickening our choroid right here. And then our vitreous is kind of cloudy, hazy. Anterior segment does not look particularly exciting. And then our left eye, it does look like maybe there's a bit of a cataract. It's just a little bit cloudier. But there is a similar process happening in the posterior segment. So kind of this similar infiltrate within the vitreous and maybe subretinal space. There is also kind of this more discrete mass effect within the choroid, maybe in the sclera too. It just looks a little less distinct right here. Okay. So switch over, look at the histology. And we will start with the right eye. There's kind of the lesions of both eyes are somewhat similar. Let's see if we can do this. Okay. Right on the edge of the slides. I'll have to kind of hold it. Sorry about my shaky hands. Also not focusing very well. At the most I can bring it down.
Try to get the other end also the same.
Like here, there we go. Yeah. This might be hard for me to do.
Use the prime focus to get it further.
Okay. This is a little more. There we go. Okay. Thank you all. Good teamwork. All right. So as we grossly saw, anterior segments relatively unremarkable. Let's see if I can grab my mouse too. Cornea, lens don't look particularly exciting. From this view, also the anterior uveal tract is also pretty bland looking. As we move back, here's our little optic nerve and optic nerve head. Here's our retina. It is definitely detached. It does look maybe a little bit busier, like there is some sort of cellular infiltrate. There's areas that look just a little bit more purple, which usually means cells. And then also within our choroid in the subretinal space, again, there's just kind of more purple. And sometimes it does cause this expansion of the choroid itself. All right, so we've flipped the globe 90 degrees or rotated it. So cornea is going to be on the right, posterior segment to the left. And I don't really have too much to say about our anterior segment, so we'll kind of just move past that. Maybe here and there, there's a little bit of inflammation. It's really not particularly striking. Just looks like maybe just some little lymphocytes and plasma cells scattered here and there, but pretty mild. As we move back in our vitreous, there is kind of just this hazy eosinophilic material, maybe some cells scattered here and there, some erythrocytes as well. But probably the meat of this section is in our choroid, where we have this cellular infiltrate causing this expansion of the choroid. And it's, as we get closer, looks like a fairly heterogeneous population of cells. And these are inflammatory cells. So we have some neutrophils with their segmented nuclei. And then we have these larger cells with a more open chromatin pattern. So these are macrophages. And sometimes there's kind of variable amounts of melanin pigment within their cytoplasm. As we kind of move around, it's a pretty consistent infiltrate. There are some areas where maybe there's some lymphocytes and plasma cells right here. Some
more mononuclear cells, but the infiltrate is mostly pyogranulomatous. And these cells spill out into the subretinal space as well. There they are. And if we move up to our retina, find an area where it's less wrinkled. This is a true retinal detachment. We have material in the subretinal space to corroborate that. Also, we do have this atrophy of the outer nuclear layer. So there's loss of the inner and outer photoreceptor segments, and then just fewer cells that make up that outer nuclear layer as well. We don't see as many nuclei. And in some areas, there are inflammatory cells within the retina itself. So again, there's maybe some lymphocytes in here, other areas with more perhaps macrophages, just kind of scattered here and there. And I'm going to quickly hop on the left eye just to compare. I'll just go straight to putting it onto the stage. Similarly, anterior segment looks pretty good. Maybe there are some cells in the anterior uveal tract, but not many. This is the eye that did have the advanced cataract, and we can certainly corroborate that. There are some nice lesions we associate with cataractous degeneration. So we're still in the anterior aspect of the lens where we have our lens epithelium. As we move back, is also present posterior. So this is posterior migration of the lens epithelium, which is one of our cardinal signs for a cataract. In addition to that, we also have this liquefaction of the cortical lens fibers with formation of these more Gagnian globules, which is another hallmark sign for a cataract. So we can confirm. And yeah, I can imagine it would be hard to see past this to see into the posterior segment. So we have a similar infiltrate, maybe more severe in this eye, within subretinal space, choroid, a little bit in the vitreous. Here is our detached retina, that look heavily infiltrated. And here is that mass effect that we saw grossly. So making kind of a more discrete mass effect, and there is some degree of scleral infiltration too. Moving down, focusing, just showing more closely. It's a similar inflammatory population. So neutrophils, macrophages, maybe some plasma cells and lymphocytes scattered here and there. All right. So pyogranulous inflammation, as Dr. Miller has already kind of covered, we definitely want to be thinking about infectious disease. So we just do some special stains to look for infectious agents. We'll just move straight to our GMS stain, which is a silver stain that stains polysaccharides. We usually use it for looking for fungal organisms. So there's a little bit of an artifact here, just me scratching the cover slip. Ignore that. Really like doing that. And we'll go straight into kind of where that mass effect is. Focus. There we go. Down. Ooh. So within this population of mostly macrophages here, sometimes there is some melanin pigment that we have to kind of ignore. Melanin is kind of one of the more annoying aspects of trying to look at a GMS. But looking past that, within the macrophages, in their cytoplasm, there are these kind of oval to round silver staining organisms. So these are fungal organisms. And
the 60x on this one.
The 60x, yeah. Let me focus with my shaky hands. Okay. Right over here. Maybe we have some, yeah. It's very cute.
They're buds.
They're buds. Oh yes, best friends. So these are fungal organisms within the cytoplasm macrophages, this size, this morphology in a cat. Most likely this is going to be histoplasma. And they are scattered here and there. This is probably the area where they are most numerous. Sometimes they can be really tricky to find, very sparsely distributed. But there are some areas where they're within the exudate too. Just a few of them here and there. I won't waste our time trying to find them.
Great GMS though.
Yeah, this is really nice. Yeah, sometimes the GMS will stain nuclei. It can be really hard to read through that. This one has, yeah, they did a really good job. It's a very clean stain this time. Okay.
And if you go back to the H&E, just pretty quick, I think I saw them on the H&E, but I'm like, it's always
Yeah, I went
hard.
back to it after doing the stain. Like maybe there's some.
Once you landed there were
I'm always skeptical.
suspicious things in there. Of course, going back to GMS to the H&E, it's like Monday morning quarterbacking, Oh yeah, they're all obviously there, but I wouldn't make the call without.
Yeah, like sometimes there's like these
GMS.
vacuoles, like,
Mhm.
meh, yeah.
So move around. Well, the when you landed first on the H&E on this area, I was
Oh,
like,
goodness.
but I didn't want to.
I don't know if I can recreate the wheel. I think I kind of landed over here somewhere.
Right there, yeah. Try.
Okay, one more.
We
This is
obviously
the
got,
time.
a couple minutes to.
1 minute.
Let's see. Yeah.
The lower left of the screen, maybe.
Left of screen.
Yeah,
yeah.
right there. Keep going right there, and a little bit more
Yeah, a little
Yeah, on
bit
this
more
side?
southeast, west.
to the left. Yep,
Yeah,
right.
those
Yeah, those
four.
guys.
Maybe,
Mhm.
could
There they
be.
are.
I like this.
That's
The
how
fun
hard
scavenger
it is.
hunt. Little Where's Waldo.
As I said, knowing what their GMS looks like makes it.
Yeah,
Oh yeah, look at that.
these little guys here.
Yeah, probably.
Nuclear
Mhm.
debris, afterthought bodies.
Yeah.
It's chaos,
Yeah, when it's so chaotic, definitely GMS is our friend here.
indeed.
Okay. And I did also do a GMS on the other eye. Their organisms were in the eye as well, just not quite as nice as this left eye. So
Where's this animal from?
this animal's from Minnesota.
Okay.
So yeah, in both eyes, we had a pyogranulomatous, chorioretinitis, and endophthalmitis with the intrahistiocytic fungal yeast that are most consistent morphologically with histoplasma. And in most cases of ocular histoplasmosis, usually it's an ocular manifestation of systemic histoplasmosis. So likely this cat is systemically affected. In this case, we have bilateral involvement. The fact that the posterior segment's mostly involved also corroborates the fact that probably it's systemic in this case, unfortunately. And I think we're about at time. 3 minutes. I don't know if I have enough time to go my last one, so I'll skip it for now. Great. So if there's no other questions, anything?
No, we're good.
Right, then we'll end it there and we'll see y'all in 2 weeks.
Everyone.
I can do this and